In our last talk, we covered what happens when cells cross the line into injury and death. Today, we're looking at something that happens before that line, adaptation. When cells face stress that isn't immediately lethal, many of them don't just sit there and take it. They change, they adapt. And understanding those adaptations tells us a lot about what a patient's body has been dealing with and for how long. Cellular adaptation as a survival strategy. Cells are remarkably plastic. They can remodel themselves in response to what's being asked of them. The key insight here is that adaptation is purposeful. A cell isn't randomly changing, it's responding to a specific signal. And the type of adaptation it makes tells you what kind of signal it's been receiving. That's the systems thinking piece. The adaptation is a clue to the stressor. Hypertrophy means the cell gets bigger, not by dividing, but by building more internal machinery, more myofibrils in a muscle cell, more smooth ER in a liver cell processing drugs. The cell is literally bulking up to handle a heavier workload. Now here's the important distinction. Hypertrophy isn't always bad. A racehorse has hypertrophied cardiac muscle because of training. That's physiologic. But a dog with chronic mitral valve disease develops cardiac hypertrophy because the heart is working against abnormal pressure. That's pathologic. And over time, the heart can fail because hypertrophy has limits. Same adaptation, very different prognosis depending on context. Hyperplasia is different from hypertrophy in one critical way. Instead of the cells getting bigger, there are just more of them. The cell size stays the same, but the tissue gets more populated. This requires cells that can still divide. So you'll see hyperplasia in epithelial cells, bone marrow cells, and glandular tissue, but not in neurons, which can't divide. Canine benign prostatic hyperplasia is a perfect clinical example. It's driven by hormonal signals, it's reversible with castration, and the cells are still normal looking. That last point is key. In hyperplasia, the cells look architecturally normal. When they start looking abnormal, we start worrying about dysplasia or neoplasia. Atrophy is a cell's way of saying, I'm not getting enough resources to maintain my current size, so I'm going to downsize. It's actually elegant survival biology. The cell activates autophagy, a process where it literally digests its own non-essential components to generate energy and building blocks. The result is a smaller cell that can survive on less. You see this in muscles that haven't been used. Cast a limb and come back in 4 weeks, and the muscles are visibly smaller. You see it in testicles after hormonal loss. You see it in the pancreatic exocrine tissue of cats with chronic pancreatic disease. The tissue is shrinking to match what's available. Metaplasia is the most sophisticated adaptation on our list. The tissue is actually changing its identity. The original cell type is replaced by a different cell type that's better equipped to handle the new environment. Here's the important mechanistic detail. It's not that the differentiated cells are transforming into something else. What's happening is that the tissue stem cells are being reprogrammed to produce a different cell lineage. In the airways of a chronically irritated animal, think smoke inhalation, chronic viral infection, the delicate ciliated respiratory epithelium is replaced by tough stratified squamous epithelium. The cilia are gone, which is bad for mucus clearance, but the tissue is more resistant to the ongoing irritation. The danger is that if the irritant persists, metaplastic tissue has a significantly elevated risk of becoming neoplastic. Dysplasia is where we start to get worried. Unlike hypertrophy or hyperplasia, where the cells look normal even if the tissue has changed, dysplastic cells look abnormal. They're different sizes, different shapes, their nuclei are enlarged and irregular, and the normal architectural organization of the tissue is disrupted. Dysplasia is not yet cancer, but it's the last warning sign before that line is crossed. Think of it as adaptation that has started to lose its discipline. Carcinoma in situ is dysplasia that has become so severe that it looks malignant, but it hasn't broken through the basement membrane yet. Once it does, it's invasive cancer. Here's how I want you to think about all 5 adaptations together. They exist on a spectrum of stress response, from relatively benign and easily reversible to increasingly risky and closer to the neoplastic line. Hypertrophy and atrophy are the most benign. The cell is just matching its size to demand. Hyperplasia introduces more cells, which means more opportunities for mutations. Metaplasia changes tissue identity under persistent irritation. And dysplasia, it's the last stop before cancer. When you see any of these on a biopsy report or necropsy finding, ask, what has this tissue been dealing with and for how long? The adaptation is the clue. Ideas to carry with you. The most important one is the last. Use the adaptation as a diagnostic clue. If you see cardiac hypertrophy, something has been overloading that heart. If you see squamous metaplasia in a bladder, something's been chronically irritating that epithelium. If you see dysplasia, the tissue has been under severe sustained stress, and you should be worried about neoplastic progression. These aren't just descriptive terms, they're a story about what that patient's body has been experiencing. The video, read the question, try to work through it yourself, and then we'll work through it together. This is benign prostatic hyperplasia, BPH. The key findings are symmetrically enlarged, the cells look normal, and the increases in cell number, not cell size. That's hyperplasia. The driver is hormonal, specifically chronic testosterone exposure and its conversion to dihydrotestosterone within the gland, which stimulates glandular cell proliferation. Because it's driven by hormonal signal, it's reversible. Castration will cause the prostate to involute. The fact that the cells look architecturally normal is what separates this from a neoplastic process. Always note the cell appearance when you're characterizing a proliferative lesion. Read the case scenario, give it a try, and we'll work through it together. This is disuse atrophy. At the cellular level, the reduced mechanical loading causes a decrease in anabolic signaling, the signals that tell the cell to synthesize new protein. At the same time, protein degradation pathways remain active. The net result is that protein synthesis falls below protein degradation and the cell shrinks. Additionally, autophagy is upregulated. The cell starts digesting its own organelles and proteins to maintain energy balance. The muscle fibers become smaller in cross-sectional diameter, which grossly appears as muscle wasting. This is reversible with resumed exercise. The mechanical signals return, protein synthesis ramps back up, and the cells rebuild. But prolonged atrophy can lead to connective tissue replacement that limits full recovery. Watch the video, read the case, give it a try, and we'll work through it together. This is squamous metaplasia of the bladder epithelium. The normal transitional epithelium, also called urothelium, is being replaced by stratified squamous epithelium, which is tougher and more resistant to mechanical irritation. The chronic abrasion from bladder stones is the stressor. The stem cells in the bladder wall are being reprogrammed to produce squamous cells instead of transitional cells because squamous epithelium is better equipped to withstand continuous physical trauma. The important clinical note, if the stones are removed and the irritation stops, this metaplasia can regress. But if the stones persist and the stressor continues, this metaplastic epithelium has an elevated risk of undergoing dysplasia and eventually developing into squamous cell carcinoma. The video, read the case study, and give it a go. We'll then work through it together. This is dysplasia, specifically carcinoma in situ, given that the abnormal changes are confined to the epithelial layer and haven't breached the basement membrane. The descriptors are the classic dysplasia checklist. Pleomorphism means the cells vary in size and shape. They've lost uniformity. A high nuclear to cytoplasmic ratio means the nucleus is disproportionately large, a sign of abnormal proliferative activity. Loss of normal architectural organization tells us the tissue has lost its discipline, and increased mitotic figures confirm rapid, poorly regulated cell division. Confined to the epithelium with an intact basement membrane is the defining feature of carcinoma in situ. It's the last exit before invasion. If the basement membrane is breached, it becomes invasive carcinoma and the prognosis changes dramatically.